Hey, Dr. Frank here. Another clinically relevant video. This one's on the resetting of the neuromuscular balance in the lumbopelvic region. This is a person that began having hip pathology issues from being a dancer at about age 16. She's now 34. What exacerbated things certainly was three pregnancies and three vaginal deliveries. And in the last two, she had this progressive diastasis that developed that was, fairly significant. Even in a little bit of an umbilical hernia that happened after the third one. But 6 months she had pelvic floor PT and it did help with her back pain. But what she said was she never really fully felt like she got her muscle tone back, like she was really able to recruit in and around the lumbopelvic region. So, now she presents and her current signs really are continued low back pain, really soreness around the lower abdominal region, popping and grabbing of her hip, sort of almost like a labrum type of issue when she's putting pressure through her hip flexors, and difficulty with squatting and those types of things, any kind of functional movements where she's loaded. So in the very first presentation, we were in class here. This is what she looked like and what she said.
I can feel the couch.
And that's why you think you have the...
Yeah, and even with the max amount of like finger on, how do we contract? What are we stabilizing with? It feels like I get to a point in my psoas, I can feel just above like catch, and I can't smooth.
And that's why you think you have a cartilage problem.
I think I have a cartilage problem because when I do like a lot of deep squats and things like that, I'll get a lot of pain and deep capsule, like deep hip stuff. That's harder to reproduce.
So she's talking about really unable to contract the abdominals, so it appears her hip flexors are really kind of taking over for her, right? So there's an asymmetry there. What did we do with her? Well, we did single needle into the key areas that I list below here. We didn't do any twitching or pistoning or anything like that. It was very focused. We did some needle rotation, again, trying to stimulate the right type of neurology that I'm looking for. But her ilioinguinal and general femoral nerve distributions were on fire in those lower abs, right? We were able to take care of that. I did do rectus abdominis needling bilaterally, and we're doing it at the emergent points of where the intercostals come out between the rectus. This was an area that, again, reproduced a lot of her discomfort. I did an insertion of a rectus abdominis off the pubic, and we did a posterior deep approach to the iliopsoas muscles and add a little bit of electrical stim to it. So just basically here, this is just kind of showing around the L4 region is where we want to get to that posterior iliopsoas. The safest way to get there is that. And then this isn't her, but this is a representation of her diastasis and kind of where we needled. We had to make some significant changes because of the change of anatomy on where their intercostal muscles, or where the intercostal nerves came out between the muscles. So we did some basic needling in this distribution as well. Now, after, this is what she looked like.
I have never been able to feel lower abdominals when I do any sort of like bicycling or like double leg. I always feel psoas. I don't feel.
Do you feel strong there?
Yes.
She looks stronger.
Yeah.
Like stronger, more coordinated.
Yeah.
So again, it goes back.
So was she stronger, right? No, we just took away the nociceptive signal. We took away the inhibition, and now all of a sudden her abdominals are starting to contract. And what you didn't see in that picture was how poor the contractions were of her abdominal regions. It was very asynchronous. It was almost like just contracting. Nothing actually happened together. After we needled the abdominals, everything became synchronous, which was the key piece. And then we cleaned up the iliopsoas, and she got good results. Now, does it last? Well, this is her about 9 days later.
Don't feel it in my hip. There, but this side I don't feel it in my hip. Yeah.
So she felt a little pop in her left hip, but it's her right hip actually that's involved with this. So we're able to maintain this change over a significant period of time. Now we're going to need to do some cleanups and things with it, but we're able to maintain it over time. So we had a long-standing issue since high school in the hip that appeared to be cartilaginous, and maybe it is, but by changing the neuromuscular patterning, getting the abdominals, getting the psoas to actually contract synchronously, we start to change that neuromuscular patterning, right? We change her pain, we change her recruitment patterns. She can generate and attenuate force. So I kind of liken this to a resetting of the neuromuscular complex, right? It's almost a control-alt-delete where you're shutting certain things off, turning other things on, and just resetting the mechanism. So that's kind of what we look at. That's how we do neurological dry needling. So hope you enjoyed it, and we'll definitely talk soon.